The other piece of this is I work with adult individuals who have borderline personality disorder, and I actually help try to manage and hopefully prevent suicide attempts. And so the other presentation was a workshop for psychiatric residents and fellows on the management of borderline personality disorder, and I gave the piece on suicidality. I spoke a lot about how, and actually I asked the audience, it's very interesting, I asked them how many individuals, and there were about 200 people in the audience, had experienced a patient with borderline personality disorder who had a suicide attempt. I'd say 95% of the hands went up. I then asked how many people had actually had a patient who successfully killed themselves, and only about 8 or 9 hands. And I think that's the crux of the discussion, which is how do you determine which of the patients who are attempting suicide are going to go on to complete suicide? As a field, we're not very good at figuring that out. There's about a 10%, maybe 8 to 10% range of people who will go on, and we're not very good at figuring out who those people are. Most people who kill themselves do it on the first attempt, so we, as psychiatrists, don't actually see those people. Maybe our colleagues in internal medicine and primary care might be, so that would be an avenue to be addressing the people on the first attempt. But if you're a psychiatrist and you're treating people who have had a suicide attempt, how do you manage them? How do you know if they're going to go on to be an eventual completer? And then some of the strategies around hospitalization, no harm contracts, which is sort of an outdated way of thinking about suicide, and more about suicide safety planning, which is kind of what's in vogue now. One of the things that we've learned about this disorder is some of the symptoms of impulsivity and self-destructiveness. They do kind of die out over time, excuse the expression. They do over time, not as important. But the sense of emptiness, the sense of despair and hopelessness, that continues throughout the lifetime, and as a field we're really trying to figure out how to manage that. It's interesting, I'll go back to that first survey that I was talking about. Parents do identify that there's something temperamentally different about the ability to kind of feel joy and feel misery. They actually feel like their infants have a different kind of disposition about affect. How that leads to suicide, you know, probably coupled with impulsivity. The individuals who do end up completing are usually using drugs. They might have a comorbid antisocial personality disorder. There's something a little more than just borderline personality disorder. It's one of the few disorders, I think there's 2, that actually have suicide as part of the diagnostic criteria. So tells you that that's a really important feature. So I'm constantly vigil and kind of asking, I might say, if I had any thoughts, you know, has it come through your mind at all? And it may not be a feature for parts of the treatment, and then it may become an issue if there's some kind of trauma or some kind of trigger or some kind of disappointment that occurs. But not every borderline patient is suicidal, but it certainly is an important aspect of the treatment. I actually think suicide attempts is a piece of working with borderline personality disorder. It's the behavioral manifestation of that inability to regulate negative emotions. So it gets too upsetting, and so you act on it, and that is a feature. And so the treatment is really about helping people better regulate their emotions, other kinds of coping strategies beyond trying to take your life. Now, it's interesting, I consider myself somebody who's an expert in suicide attempts. I'm really not an expert in suicide completions, and I think that was kind of the message that I wanted to convey to the trainees and fellows and residents in the room. There's a lot of stigma attached to having the disorder. In fact, a lot of clinicians don't want to label their patients with borderline personality disorder. It's often the label that's given to difficult patients. These are individuals who have anger problems, they have interpersonal problems, and they can appear manipulative, which is all part of the kind of the symptom profile. So I think it's to try to raise awareness that that is the disorder. It's an inability. They're doing the best they can at the moment, and they need to be able to learn other skills to get their needs met and to have their maladies understood.